Hello, I'm Nikki Harding. I am clinical educator here at Phyllis Tuckwell Hospice Care, and this video is going to be a practical demonstration to support the theory that you've already looked at in our presentations. We're going to discuss the registered nurse verification of expected death in light of the COVID-19 changes, and as such obviously you will be wearing your PPE as recommended by Public Health England. I have on my apron and my gloves. Normally I would be wearing a mask, but for the purposes of the video I'm not going to wear it, just for clarity of me speaking. Within this demonstration we're going to be using our mannequin, whom I will refer to as Kerry, and we will take you through the verification process. So the staff looking after Kerry have recognised that she has died. Prior to this, there has been full discussion with all of the interdisciplinary team caring for her, and the team have agreed that there are no reversible changes to her condition, and that everybody is in agreement that Kerry is reaching the end of her life. The GP will have seen Kerry and will have agreed that they are happy for a registered nurse to verify her expected death. So coming into the home or into Kerry's room, I will want to identify the patient, and the terminology, as you know, is that the patient has been identified to me as Kerry. So I'd be using the family members and Kerry's notes and documentation to actually just verify that I had the correct patient in front of me. The other things I would be observing would be Kerry's colour. I might feel her to feel that she is indeed cold and has passed away. The other thing about a patient who has COVID-19 or suspected COVID-19 is we might want to cover the mouth and nose area of her body just for safety. Obviously I will also be wearing my mask, remember, but just to cover her nose and mouth for my safety as I'm working around her. This verification process is slightly different to the normal one, in that the recommendations are that we use a clean area, a sterile field, and a double glove technique so that I can keep my equipment clean. Although this is a sterile dressing pack, I'm just using it as a clean field, so I am touching it more than I normally would. But within this pack there should be a second pair of gloves, and I am going to use a double glove technique. You'll see later that this is to make sure that I can keep my equipment clean once I've used it. So the equipment I will use is a pen torch and a stethoscope, and all of this will be with me into the room for my patient. I'm going to lay these on my clean area in preparation. So the order I'm going to use this is as per guidelines that you will have already looked at, looking at verification following the COVID-19 changes. The first thing I'm going to do is listen for the absence of any heart sounds. This is best listened to in the fifth intercostal space, which is in the mid-clavicular line. So here is Kerry's clavicle, her collarbone, and the middle of that I can then feel the spaces between her ribs, so space 1, 2, 3, 4, 5. So I'm going to place my stethoscope here and look for or listen for absence of heart sounds. Really important with the stethoscope that you know that the earpieces go in the same direction as your ear canal. It's important to listen to the fact you can make sure you can hear. Obviously I'm looking for absence of sounds. I need to know that I am going to hear them. So I'm just going to place this in the 5th intercostal space. I'm going to listen for 1 full minute, timed on a clock. And as that minute completes, I can confirm that there are no heart sounds. I'm going to replace my stethoscope onto the clean area of my trolley. So, really important that we listen for 1 full minute in case the heart rate is really, really low. You're just listening for that full minute to make sure you're not missing any beats. The next thing I'm going to test is Kerry's pupil reflexes, and I'm going to be using my pen torch. So I'm going to cover Kerry's eye and then bring my pen torch in from the side, and you can see that Kerry's pupils are fixed and dilated, not responding to light. Just in case there are any changes eye to eye, I will also check the other side. And I'm just checking Kerry's neurological responses, and her pupils remain fixed and dilated, no response. I'm going to replace my pen torch onto my clean field. The next thing I'm going to check is Kerry's respiratory function. I'm looking for any movement whatsoever. Obviously I'm expecting no movement to be there. So I'm going to look at both sides of the chest for a full 5 minutes. I'm not going to get near Kerry's mouth or nose at all because of the infection risk, but I'm just going to observe both sides of her chest in case she's had any previous lung surgery, in case there's any consolidation or pleural effusion, one side that might stop the rise and fall of her chest. So again, timed by the clock, I'm just going to watch any movement. And after my 5 minutes has gone by, I can confirm that there is no respiratory effort from this patient. I'm then going on to check for any pulses. I'm going to check Kerry's carotid pulse, but if a patient has any problems with their neck, then you may need to look for the femoral pulse. But in Kerry's case, the carotid, so I'm just going to locate where the carotid would be at the side of the trachea beside the Adam's apple. And again, using my clock, I'm going to try and feel any pulse for a full minute timed on my clock or watch. Again, the reason that you're doing all of this is just to check for any faint pulse, any faint movements. And after my full minute, I can confirm that there is the absence of any pulse with Kerry. The final test I'm going to do in this verification process is to again check the neurological system and check for any motor response, and I'm doing that with a trapezium squeeze, the triangular muscle that goes from your neck across your back, and actually pinching and squeezing. That muscle is extremely painful and there would normally be a response, and I can confirm that Kerry is not responding, she's unresponsive. So I verify that through doing all of these checks that Kerry has died. At the end of this verification process, I want to make sure that Kerry is left in a dignified way, because once all of my documentation is complete, she will be released to the undertakers. The last thing I can do is to remove any medical devices that Kerry has, and I know from her medical notes, her clinical notes, and the teams looking after her that she does have a syringe driver in situ, which is in her right thigh. So again, preserving her dignity, I can actually make record of the syringe driver. So I need to record the amount of drug that's remaining that I'm going to discard. The syringe driver may have been turned off by the teams looking after her, it may still be running. This one's been turned off. I'm just going to turn it on again, so that as long as the syringe has not been removed, I can actually make my measurements of the volume remaining. So it says press yes to resume. I'm just going to reset it going again so that I can take my measurements. So pressing the blue info key, it tells me volume infused, volume to be infused, and I need to make a note of those volumes on the documentation. I'll need to remember that for now because I'm still all gowned up, gloved up and so on. I can then turn the syringe driver off. Wait for the beep. Removal of medical devices within this COVID-19 situation is slightly different in that I'm actually going to use a cap to cap off the cannula but remove the syringe driver. This is to minimise the amount of risk of contamination. So this may be the same for any other medical devices. I'm going to put my syringe driver in my clean area here, ready to be cleaned. So other devices that may be in situ, a catheter would be spigoted, not removed. A venflon would be capped off. Any long lines, PICC lines, Hickman lines, any central lines would be capped off. So you would not remove any medical devices, merely spigot or cap them off to minimise infection risk. I've now completed my work with Kerry. I'm going to make sure that she is laying flat and she is fully covered and dignified so that the funeral directors would then take over her care. Because I've now finished that part of my work, I'm going to remove my double gloves, discard them in my bag. And then I would then use my 70% alcohol wipes to clean all of my equipment. So I would be cleaning my stethoscope. I would do it properly. I'm not going to do it properly now. I would be cleaning my pen torch and the syringe driver, the outer box and the syringe driver itself. The actual medication would be destroyed, discarded by removing it from the syringe driver and then discarding it either into the gel in the sharps bin or using the denaturing kit, the dupe kit, and that would all be then discarded. I would then take my cleaned equipment and put them in a clean bag ready to take out of the patient's room or out of the patient's home. And then I would take that and leave the patient's room and dispose of all of my PPE. You would be following the regulations, obviously your mask as well, regulations from Public Health England about taking off your PPE. That would go into a double bag and that would stay in the patient's home for 72 hours following those guidelines. The last thing I would have to do would be to use the verification of expected death form that you have already explored in your theory. And within that form there is space to record the volume to be infused, the volume remaining in the syringe driver, as well as all of the other checks. So that concludes this part of our demonstration. The next stage for you would be to complete your competency form. You need to work with your assessor in practice to actually be signed as competent for the registered nurse verification of expected death.